Hope all of you are attending this session. Today I'll be talking about the breast and physiology of lactation pertaining to our antenatal and postnatal care. So we will not be going through the surgical anatomy, only the pertaining part that is required in the postnatal and antenatal period. Okay, so sorry. So what we'll be covering in this topic is the breast anatomy, where it is situated and the relations, the deep relations, the structure of the breast, the blood supply, nerve supply, lymphatic drainage and development, and also we'll be going through physiology of lactation. So what are the breasts? Also called as a mammary gland. So all mammals feeding milk, that's why. So breast is called mammary gland. So the breasts are large, modified sebaceous glands, usually bilateral, well developed in females. In females, it constitutes the accessory reproductive organ. The glands are concerned with lactation following delivery or childbirth. So where are the glands situated? Are in the subcutaneous plane, overlying the pectoralis muscle. So there is fat surrounding the glandular tissue, which determines the size of the breast. The greatest prominence of the breast is the nipple. A circular pigmented area of the skin around the nipple is called the areola. So just look. So over the pectoral fascia, this is the pectoral muscle. These are the ribs. This is a cross section, okay? These are the ribs. So, and this is the pectoral fascia, and breast lies in the subcutaneous plane. This is the fascia, okay? This is the fat. This is the glandular tissue. Okay. So, how is the anatomy? It extends from the second to the sixth rib in the mid-clavicular line. So, the size of the breast is determined by size and shape of the breast are determined by the genetic, racial, and dietary factors. As I told you, it lies in the subcutaneous tissue over the fascia covering the pectoralis muscle. So, in the mid-clavicular line, okay? So, look at this. This from the second to the sixth rib, extending from the second to the sixth rib. This is the pectoral muscles. So this is the basement. This is the base of the breast. A lateral projection of the breast towards the axilla is known as the axillary, the tail of Spence. It lies in the axillary fossa, sometimes deep to the deep fascia. So, a non-lactating or non-pregnant breast weighs 200 to 300 grams during the childbearing age. So, I told you this is a surface anatomy of the mammary gland. It extends from the second rib to the sixth or seventh rib. This is the axillary prolongation, axillary tail of Spence. Okay, tail of the breast. This is the prominent projection called the nipple, and this is the pigmented area which is called the areola. The craniocaudal diameter is 12 to 15 centimeters. This is called the inframammary crease. So, about 2/3 of the breast lie on the deep fascia related to the pectoralis major muscle. The 1/3 rest on the fascia covering the serratus anterior muscle. A layer of loose connective tissue. There's a space called retromammary space, separates the breast from the deep fascia and provides some degree of movement over the underlying structures. So look at this. This is the clavicle. This is the first rib. So this is the second rib. This is the pectoralis major muscle. So there is a fascia, that is the deep fascia. So there is some space. This is called the retromammary space. So like I told you, the retromammary space separates the breast from the deep fascia and provides some degree of movement over the underlying structures. So, how is the shape of the breast? Predominantly it is circular, except minor oblong part which extends further into the axillary region. It is called the axillary tail. So the breast is divided into 4 quadrants. What is areola? Areola is a darkened area around the nipples. Glands of Montgomery. These are small sebaceous glands that produce sebum, oily substance. These enlarge during pregnancy and provide lubrication and protection to the nipple. So what is the nipple? Nipple is the terminal ends of the milk duct. Deliver milk to the baby. Both areola and nipple have erectile smooth muscles which also prevents it leaking. So here you can see this is the oblong extension which is called the axillary tail. Okay, so look at this is the nipple, the areola, and you can see elevated papules like thing. These are the here you can have a clear look. These are Montgomery's tubercles. They produce a oily sebum-like substance which provide lubrication to the nipple. So the anatomical position of areola is placed above the center of the breast and is pigmented. It is about 2.5 centimeters in diameter. I have repeated these terms so that you get familiar with the structures of the breast. So previous slides also I have talked about nipple, areola, Montgomery glands. Again I am repeating so that you can remember well and get familiar with the terminology of the breast. So the areola is placed about the center of the breast and is pigmented and is about 2.5 centimeter in diameter. Montgomery glands, these are, as I told you, are accessory glands located around the periphery of the areola, and they also can secrete milk. So we'll be talking about nipple again. The nipple is a muscular projection covered by pigmented skin. It is vascular and surrounded by unstriated muscles. So it can be soft and it can be erected. Because of this, they are surrounded by unstriated muscles, which makes it erectile. It accommodates about 15 to 20 lactiferous ducts and their openings. As I told you, the whole breast is embedded in the subcutaneous fat, but this fat is absent beneath the nipple and the areola. So we'll go through the composition of the breast. So the mature breast, it consists of 20% of glandular tissue and 80% of fat, and rest the connective tissue. So each breast is composed of 12 to 20 lobes, and each lobe has one excretory duct, lactiferous duct, that open at the nipple. Each lobe has about 10 to 100 lobules. So Cooper's ligaments, these are a fibrous septa. They extend from the skin to the underlying pectoral fin. These are fibrous strand-like structures. I will show you in the diagram that extends from the skin to the underlying pectoral fascia. These ligaments provide support to the breast. One lactiferous duct drains a lobe. So look at this. This is the glandular tissue. This is the fat or the adipose tissue, skin, pectoralis major, retromammary space, and these ribs. So look at this picture. This is a lobe, then the lobules, the mammary fat. These are the alveoli and the ducts, and this is called the ampulla. This is the, so 15 to 20 lobes are present. Then look at the lobules. These are the lobules. And look at these strands, these yellow strands. These are the fibrous septa, or called the Cooper's ligaments. Then into alveoli, then into ducts. So lobules and their ducts and ampulla and then into the nipple. So you can look at here. This is the fascia. These are the fibrous septa or the Cooper's ligaments. Sorry. This is the glandular tissue, and the rest is the adipose tissue or the fat. So 80% is fat. So we'll go through the histology. The lining epithelium of the duct is cubical, becomes stratified squamous near the openings. Each alveolus is lined by columnar epithelium where milk secretion occurs. Whenever there is secretion, there is always columnar epithelium. I hope you all know. A network of branching longitudinal striated cells called myoepithelial cells surround this alveoli and the smaller ducts. So this is the histology. These are the branching ducts. This is the large interlobular duct. These are lobules. This is the and these are secretory alveoli. And this is the intralobular duct. So intralobular duct and interlobular duct. So here we'll go through. So this is the chest wall, and these are cross sections of the breast. This is the pectoralis major muscle. This is the fat. These are the lobules. So you can see the duct, enlargement of the duct. You can see these are normal duct cells. This is the basement membrane and this is the lumen. This is the picture. You can look at the radiographic picture of the breast. Chest wall, ribs, and Cooper's ligament. So we'll go through the arterial supply of the breast. The blood supply to the breast is derived from these blood vessels. That is the mainly it is part of the second part of the axillary artery, the lateral thoracic and thoracoacromial arteries, which are branches of the second part of the axillary artery. The posterior intercostal arteries, a branch of the thoracic aorta in the second, third, and the fourth intercostal space. And medial mammary branch of perforating branches of anterior intercostal branches of internal thoracic artery. So look at this blood supply. This is the axillary artery, the internal thoracic artery, and the lateral thoracic artery. And the venous supply also follows the same pattern. These are the, from the aorta, these are the intercostal arteries. So look at the blood supply and the arterial supply. As I told you, internal thoracic artery and its perforating branches, the medial mammary branches. These are the lateral mammary branches of posterior intercostal arteries. Then the thoracoacromial branch, trunk, the brachial artery, and the axillary artery. I told you the axillary, mainly the lateral part of axillary branch, thoracoacromial trunk, and the lateral thoracic artery. Lateral mammary branches of lateral cutaneous branch, this is the venous supply. Venous drainage of the breast is mainly by the axillary vein with some assistance from the internal thoracic vein. So how the lymphatic drainage of the breast is very important. So the superficial lymphatics from the skin over the breast, except the nipple and areola, drain radially into the axillary, supraclavicular, and internal mammary group of lymph nodes. So remember, except nipple and the areola, the rest of the skin of the breast, they drain into the axillary, supraclavicular, and internal mammary group. The deep lymphatics from the nipple and areola, they drain like this. 75% of the lymph, especially the lateral quadrants of the breast, drain mostly into the anterior and some into the posterior and apical group of axillary lymph nodes. Anterior, posterior, and apical group. So they also communicate with the lateral and central groups as well. So this is the lymphatic drainage, supra, subclavicular, and the axillary rows, anterior, the nipple and the area, anterior, posterior, and the apical nodes. So look at this. Apical lymph nodes, the central lymph nodes, anterior axillary and pectoral lymph nodes. These are the internal thoracic lymph nodes. This is the lymphatic drainage of the breast. So most of the remaining 25% of the lymph, particularly from the medial quadrants, drain into the parasternal nodes or to the opposite breast, while the lymph from the lower drain into the inferior phrenic nodes. Like I showed you in the picture. So the lateral quadrant of the breast, they drain into the internal thoracic lymph nodes or the parasternal nodes. Lymph from the axillary nodes drain into the infraclavicular and supraclavicular nodes, which now drain to the subclavian lymphatic drain that also drains lymph from the upper limb. So lymph from the parasternal enter into the bronchomediasternal trunk, which drains lymph from the thoracic viscera. So this is a clear picture. Look at the parasternal nodes. These are the supraclavicular lymph nodes. This is a clavicle, right? Supraclavicular and infraclavicular lymph nodes. These are the axillary lymph nodes. They are divided into groups. They are the apical lymph nodes, humeral, central, pectoral, and subscapular. Then you have subclavian lymph trunk. This is the thing. And these are the parasternal lymph nodes. And they drain into the left breast. This medial side into the left breast. These are the submental. So nerve supply, the nerve supply to the breast is derived from the anterior and lateral cutaneous branches of the fourth to the sixth intercostal nerves. The branches of the intercostal nerve passes through the deep fascia covering the pectoralis major to reach the skin, including the breast of the subcutaneous tissue overlying this muscle. So now we'll go to the development of the breast. So how the breast develops from the mammary ridge. It is also called milk line or line of shells. Extends from the axilla to the groin. This mammary ridge, it extends from the axilla to. When does it appear? It appears around the 4th week of intrauterine life. So what happens in human beings? This line disappears, or the whole it disappears and only persists in the pectoral region. And breast develops from the ectodermal thickening of the persisting part of this ridge. The gland is ectodermal and stroma is mesodermal in origin. So mammary ridge, it develops from the mammary ridge, also called the milk line or the line of shells. Extend from the axilla to the groin. So this is called the two ectodermal ridges. Extend from the axilla to the groin. So this line disappears and in the pectoral region it persists, which later develops into the breast. As I told you, the persisting part of the mammary ridge is first converted into a mammary pit. Then secondary buds develop around 50 to 100, grow down from the floor of the pit. These buds, what happen? They divide and subdivide to form lobes. The entire solid system is canalized later at birth. Nipple is evacuated at the original pit. So look at this branching. The female breast before puberty. This is at puberty. This is the breast development in a young adult male. This is the development during the first half of the menstrual cycle. Second half of menstrual cycle, you see, it is more branched. This is a development in a pregnant female. Then this is in a lactating female. After lactation, again it appears like this. Then after menopause, again. So how does the breast grow? It is under the influence of hormones. So growth of the mammary gland at puberty is caused by estrogen and progesterone. Progesterone stimulates the development of the secretory alveoli. So we'll look at the cycle of changes. During pregnancy, breast becomes tender and the nipples become sore a few weeks after conception. So the most rapid period of breast growth is during the first 8 weeks of pregnancy. I showed you the Montgomery's glands or tubercles surrounding the areola. They become more darker and more prominent, and the areola itself becomes more dark. It becomes more darker. The nipples also become larger and more erect as they prepare for milk production. The blood vessels within the breast enlarge as surges for estrogen stimulate the growth of the ducts and the surges of progesterone causes glandular tissue to expand. So look how a non-lactating and a lactating breast looks like. So here the alveoli are more prominent. The nipple is more erect. So we'll go through the changes, what happens to the breast after menopause. Because during menopause, there is withdrawal of estrogen and progesterone hormones. So what happens? The breast glandular tissue, which has been kept firm, the glands that so that it will produce milk, it will shrink after menopause and is all replaced by fatty tissue. The breast also tend to increase in size and sag because of the fibrous tissue loses its strength. The breast becomes less dense after menopause and is often easier for radiologists to detect any breast cancer. Now we'll go through physiology of lactation. So what is lactation? Lactation describes the production of breast milk and its secretion from the mammary gland after delivery. So that is the definition of lactation. This is how a non-pregnant, pregnant and a lactating breast looks like. So when does lactation start? Lactation starts following soon after delivery. But during pregnancy itself, the preparation for lactation starts. So the physiological basis of lactation is divided into 4 phases. So this is called, the 5 phases are mammogenesis, lactogenesis, galactokinesis, galactopoiesis, and involution. What is mammogenesis? It is development of breast to a functional state. We will go in detail of mammogenesis and the factors influencing the mammogenesis. Lactogenesis, synthesis and secretion of milk from the breast alveoli is called lactogenesis. Ejection of milk from the breast is called galactokinesis, and maintenance of lactation is called galactopoiesis. Then after lactation, the regression and atrophy is called involution of breast. So hormones that play during mammogenesis. So in early pregnancy, you can observe there is a marked increase in ductular sprouting, branching, and lobular formation is evoked in the by luteal and placental hormones. So mammogenesis starts during pregnancy itself, in early pregnancy. So what is the role of progesterone? It causes increased growth of the alveoli size and the lobes. Estrogen, they stimulate the milk duct system to grow and differentiate and deposition of fat. So growth of the ductal system and differentiation and deposition of fat, estrogen plays a role. Then the influence. So in mammogenesis, progesterone, estrogen, and prolactin play the role. This prolactin contributes to increased growth and differentiation of alveoli and the ductal structures. So let's look. During mammogenesis, both the duct system and the lobulo-alveolar system acts. So the hormones acting on the duct system are estrogen, growth hormone, and adrenal steroids. On the lobulo-alveolar system development, all three hormones, progesterone, estrogen, and prolactin, and adrenal steroids and growth hormone. All these factors influence mammogenesis, that is the preparation of the breast. So next comes the lactogenesis. So when does lactogenesis start? After delivery, and milk secretion actually starts from the 3rd or 4th postpartum day. Here you can see there is withdrawal of estrogen and progesterone and the influence of hormones, insulin, growth hormone, glucocorticoids, and thyroid and prolactin fully developed mammary gland. Prolactin and glucocorticoids are the important hormones in this stage. The secretory activity is enhanced directly or indirectly also by the growth hormone, thyroxine, and insulin. Like I told you, growth hormone, glucocorticoids, insulin, thyroid, and prolactin is needed for the secretion of milk. For the secretory. For milk secretion to occur, nursing effort is not essential. So what is galactokinesis? As I told you, it's the ejection of the milk. And here the main hormone is oxytocin. It is the major galactokinetic hormone. And it depends on the suction exerted by the baby during suckling and the contractile mechanism which expresses the milk from the alveoli into the ducts. So here galactokinesis, the ejection of milk. So the suckling of the milk. So this is influenced by there is a reflex arc set up for this mechanism. The ascending tackle impulse. Tackle means the Tactile impulse, that means the touch impulse from the nipple and urethra passes via the thoracic sensory 4, 5, 6 and afferent neurula to the paraventricular nuclei and supraoptic nuclei of the hypothalamus to synthesize and transport oxytocin to the posterior pituitary. So, through the efferent arc or via blood, oxytocin is liberated from the posterior pituitary. So, this oxytocin causes contraction of the myoepithelial cells of the alveoli and the ducts containing the milk. There is milk ejection and milk let down reflex, whereby milk is forced down into the ampulla of the lactate, from where it can be expressed by the mother or sucked out by the baby. Presence of the infant or infant's cry can induce letdown without suckling. There is a sensation of rise and pressure in the breast by the milk experienced by the mother at the beginning of suckling, and it is called draught. So this is a conditioned reflex. So with the suckling, a conditioned reflex is set up, which goes to the hypothalamus, to the supraoptic and the paraventricular nuclei. It causes the release of oxytocin from the posterior pituitary and also the prolactin from the anterior pituitary. So oxytocin acts on the involution of the uterus on the GI hormones and GI motility. It through the T4, T5 and T6 via thoracic sensory nerves. So look at this. This is the posterior pituitary and this is the anterior pituitary. So posterior pituitary releases oxytocin. It stimulates myoepithelial cells or contracts to eject milk into the ducts. The anterior pituitary secretes prolactin and stimulates the lactocytes to secrete milk, and there is ejection of milk. So this reflex is inhibited by certain factors such as any pain due to any inflammation, any breast abscess, then breast stagnation, it's called breast engorgement, and adverse cyclic conditions. So the main hormone playing role in the galactopoiesis is prolactin is the single most important galactopoietic hormone. So for effective and continuous lactation, suckling is very important. It is not only essential for removal of milk from the glands, it is also causes the release of prolactin. Secretion is a continuous process unless suppressed by congestion or so prolactin secretion will be continuous unless it is suppressed. So milk pressure reduces the rate if breasts are not emptied and baby doesn't suckle and there is no milk ejection, there is no feedback and prolactin is not released. Milk pressure reduces the rate of production and hence breastfeeding is necessary to relieve the pressure, which in turn maintains the secretion. So here suckling is very important. So healthy mother will produce about 500 to 800 ml of milk per day. And this requires about 700 kilocalories per day for the mother, which must be made up from the diet or from her body store. Let's go through the composition of milk. The, the first 2 days, it is after delivery, the deep yellow serous fluid which is secreted. Actually, colostrum starts a little bit in the pregnancy itself. It's called colostrum. It has got a very high specific gravity, high protein, vitamin A, sodium and chloride, low carbohydrates, fat and potassium than breast milk. It contains antibodies produced locally. So the combo colostrum and breast milk. So colostrum, protein is 8.6%, fat is 2.3%, whereas in breast milk, the protein is 1.2% and fat is 3.2%. Carbohydrate is 3.2% in colostrum and 7.5% in breast milk. Water is 86% in colostrum and 87% in breast milk. So, how does stimulation of lactation occur? So, following delivery, how do you stimulate this lactation? So, immediately following, these are the steps to be followed. To put the baby to the breast at 2 to 3 hours interval from the first day. Actually, within half an hour of delivery and 1 hour, the baby is they put the baby to the breast, and plenty of fluids to drink should be given to the mother. To avoid breast engorgement, only half and 1 hour exclusive breastfeeding in correct positions are encouraged. So sometimes there is inadequate milk production, and it is which is called lactation failure. Why this occurs is because of infrequent suckling. As we talked about in previously, suckling is very important for milk production. Then only the prolactin is released. So if infrequent suckling is there, the milk production will be less, or the prolactin will stop releasing, or there is some endogenous suppression by some drugs or retained placental. Pain, anxiety, and security and insecurity may be some reasons for inadequate. Unrestricted feeding at short intervals, 2 to 3 hours, is very helpful. So, the drugs to improve milk production. So, drugs which improve milk production are called galactogogues. So, this is some of the drugs. We give metclopramide. This is an antiemetic we use. It is also improves milk production. 10 milligrams thrice daily increases milk volume 60 to 100% by increasing prolactin levels. Sulfuride dopamine antagonist has also found to be active. Intranasal oxytocin contracts myoepithelial cells and causes milk letdown. So, sometimes we need to suppress the milk, and there are certain conditions where milk suppression is required. So these are the conditions. Some women who cannot breastfeed for personal or medical reasons, they need milk suppression. So lactation is suppressed sometimes when the baby is born dead or dies in the neonatal period, or if breastfeeding is contraindicated. So most commonly methods used are, first of all, if you stop breastfeeding, there is no suckling, there is prolactin secretion is stopped, and there is no milk production. To avoid pumping, so Even if the mother expresses milk and start pumping also, there is again the stimulus for the release of the prolactin. So you have to avoid pumping or milk expression if you want to suppress the milk. To wear breast support, very tight blouses or innerwear should be worn to suppress the milk. If any engorgement, ice packs can be kept to prevent engorgement. Sorry, the spelling came as engagement. If any pain is there, analgesics can be used. As I told you, a tight compression bandage is applied for 2 to 3 days. Natural inhibition will result in breast involution. So medical methods of separation are estrogen, androgen, bromocriptine. These are the medical methods used for suppression of milk. Then, but there are many side effects. Thank you. Hope you all very clear about the physiology of lactation, how the milk production occurs. Any doubts? Any doubts? Then, if no doubts, I will end the class. Please go through this physiology of lactation chapter. In the normal puerperium, you can go through the physiology of lactation. Okay, thank you.